Welcome back to the CTO Demon channel. Today with another core curriculum talk. We are continuing on the global consensus recommendations for safety in CTO PCI paper. We're almost there. The next segment is going to talk about equipment entrapment. Now, of course, equipment entrapment can occur in any PCI, but there are some that occurs more in CTO PCI and some that are specific to CTO PCI. First, usually CTO lesions are quite calcified and tortuous. And we also have more support because we use more supportive guiding, and sometimes we have an externalized wire which gives a lot of support. Now, this is the setup for stents coming off the stent balloon and having stent dislodgement. So lesion preparation is very important. So we should do adequate lesion preparation using rotablader, CSI, using big shockwave balloons and big NC balloons to ensure that we can deliver things properly. The guide extension catheter, of course, is very helpful. You can deliver that and unsheath the stent, almost guaranteeing that you're not going to dislodge the stent off the balloon. Now, if we do dislodge a stent, in CTO PCI, usually it's better to crush the stent against the wall or to deploy it where it is rather than to try to snare it out. Because CTO PCI procedures are usually long procedures already, and snaring usually takes even longer time, and you don't want to increase operator and patient fatigue and radiation and contrast dose unnecessarily. And stenting a stent to the wall or crushing it to the wall is not really that disastrous. In fact, it's not very harmful at all in most cases. One particular CTO equipment entrapment is the knuckle wire. So knuckle wire is used really to get into subintimal space to remove ambiguity in CTO. But often, if we rotate, especially if we rotate the knuckle wire, the knuckle can turn into a knot and get entrapped in the vessel. So it's important when we push a knuckle wire not to rotate it and just keep pushing it. Fracture wire tips is also far more common in CTO because we're using CTO wires, and CTO wires, if we keep rotating it, can get trapped into the calcium and break off. Now, if we have a clear fracture tip, then it's again best to just stent it to the wall. So we just switch with a new wire and cross the CTO or cross the CTO retrograde and just stent the stuff to the wall. However, we need to be careful of wire unraveling, because when a wire unravels, instead of just a clean fracture tip, what we have is a long unravel, very thin and often difficult to see shred that comes off the wire, and it can go up into the aorta. And this can cause left main or aortic thrombosis and strokes. So it's very important to be careful to check that there's not wire unraveling. And especially in patients who are a little bit bigger in body habitus, it's sometimes difficult to see even on cine. And so it's best to put some sort of imaging device to check that the ostium of the coronary is clear of an unraveled wire. If we have an unraveled wire, of course, we should try to snare that out or shorten it, and then try to push the rest of the wire back down the coronary and to stent it. I find an easy way to do this is use a guide extension catheter. If you can snare the wire tip, the unraveled tip, back into a guide extension, and you push the guide extension down the coronary and you inject contrast, that's going to blow the rest of the wire shreds into the coronary, which you can then stent it to the wall. Now, microcatheters, again, are uniquely really CTO intervention when they get stuck to the coronary wire, because usually the only time we need to drill a microcatheter through CTO lesion is when there's a CTO. And if we drill too hard, sometimes there's fusion of the microcatheter tip to the coronary wire, and this can lead to equipment getting stuck, especially when we're doing retrograde. Because if you're antegrade, of course, and you're stuck, the worst thing you can do is pull the wire and the microcatheter out together, and usually you can do that. But in retrograde, if you're stuck, because there's also the retrograde channel that you're pulling on, very often you can't pull the retrograde microcatheter back out and you can get equipment entrapment. So it's important, in this case, prevention is much more important than cure. So we should know when the microcatheter is going to start getting stuck. And that comes with experience. I mean, I've done enough to know which microcatheter is going to get stuck at what point, and you always try to stop talking before you get to the point that the microcatheter is going to fuse on the wire. And we all go through a phase where we start fusing microcatheters to the wire and get the equipment trapping. It's better really if you start thinking this fuse should change to a small balloon or to change to a new microcatheter or some sort of a torus catheter that can allow you to drill into the lesion. Another case is, of course, when we're going through retrograde and we're snaring the retrograde wire. This is really a trap for getting equipment stuck, because if we snare a stiff wire and we pull it into a guiding, that bend on the stiff wire can fail to release from the snare, and you can get a stuck system that can't be pulled out one way or the other. So that's a very dangerous point, and that's why in the safety paper we recommend the method of snaring, and that's always to put snaring as a last resort. And if we do snare, it's preferable to snare dedicated externalization wires such as RG3 that you can snare all the way out, or it's better to snare a polymer jacketed wire. And if you do snare a polymer jacketed wire, it's easier to release, and also to use a releasable snare. The kind of homemade Sumi 2G kind of snare is recommended. Now, one other strange getting stuck place for retrograde PCI is when you have the antegrade and retrograde microcatheter tips come near each other, and they can actually fuse together. This is actually surprisingly more easy to do than you imagine. So when we're pulling retrograde microcatheter wires out, we always try to keep a little distance between the antegrade and retrograde microcatheter. The tips never touch. Otherwise, when they're touching, when you're pulling and there's some resistance, the two can fuse together, causing equipment entrapment. Now, most cases of equipment entrapment can be sorted out percutaneously, so we should have a higher threshold to refer to the surgeons to take it out. And of course, that does happen, but we should have a higher threshold. We should try to release the equipment percutaneously. Often, advancing another wire parallel to the stuck equipment and putting a balloon down and balloon to loosen it is enough to get the equipment out. Otherwise, of course, you can put a guide extension catheter and push it down, or even if you have an excimer laser that can go around the equipment and get it out. Of course, we need to, if we're going to put something over it, we need to cut the hub of whatever device we're using to be able to put a guide extension over it. And for some devices, especially imaging catheters and so on, and rotablators, we need to pull out the plastic sheath before we can put other devices parallel to it. So that's an important thing to know. Equipment fragments can sometimes be left in the coronary artery, so if we get stuck a rotor burr, sometimes we pull and the tip of the burr is left there. Again, for these devices, it's best to stent it to the wall rather than to struggle and try to snare everything out, because if it breaks at some point when you're snaring a device out, what's left of it, it really is pretty stuck. And again, as I said, in a CTO PCI, you already spent a long time and you don't want to aimlessly increase the time of the procedure, increasing operator fatigue. So this is the sort of entrapment segment of the paper. I hope you don't get entrapped equipment in your CTO PCI, but it's better to be prepared than not. So going through this segment of the paper or listening to this video, I hope can help you if you do ever meet an entrapped equipment. And of course, the tips to prevent it hopefully means that you don't meet entrapped equipment in your CTO PCI. So if you like the content, please press the like button, and of course subscribe to the channel if you want to see the upcoming. There's only 2 more videos on the safety consensus document, so I hope to record these soon and have them to you, and you have the whole set. So have a safe CTO journey. Bye bye.